Morning. Would you allow me, please, to just shift your attention from a research-based presentation to probably a wake-up call or advocacy. Maybe my topic would be read also, dear clinicians, please stop treating chronic pain like you're treating acute pain. So this is the message that I need to convey probably. Many of us are in pain, but we are not alone. It is estimated that 1 in every 4 of us will have a pain state that defies tissue healing times. And pain costs the United States in 1 year 3 times what it cost them to run wars in Iraq and Afghanistan. Imagine how many wars they could run had they not been treating chronic pain. These are the world's most burdensome health issues. They are randomly distributed, and usually in this type of exercise we ask you to give them an order of value. But I've done this for you. Actually, the Lancet did. We see that depression is the second world most burdensome health issue. Obstructive pulmonary disease ranking number 5, diabetes number 9, and so on and so forth. On the left-hand side, you will see subcategories of chronic pain. The most famous ones: migraine headache, chronic back pain, and chronic neck pain. And I want to shift them to the right side. Migraine and headache would rank number 8. Chronic neck pain would rank number 4. And obviously, chronic back pain would rank number 1. How burdensome is chronic pain? And in terms of cost to the society, and these are just some of the currencies involved, chronic pain costs society more than cancer, cardiovascular diseases, and diabetes combined. So chronic pain is the most burdensome healthcare issue facing the planet. Now we can keep on adding figures and numbers, but this will tells us nothing about the suffering. I think we're still working with a misconception. Not everybody, of course, but I mean, 350 years ago, René Descartes, the French philosopher, conceptualized or misconceptualized about pain. And then that nociception is necessary for pain. And then that we have specific centers in the brain that can be activated when pain is there. That is still among so many practices. These conceptions are still among so many practices across professional and geographic boundaries. And recently meaning 50 to 55 years ago, psychiatry defined pain by being an unpleasant sensory and emotional experience associated with actual or potential. So we know already that an actual lesion can cause pain, but a potential one can cause pain. But that multi-layered definition says that even in the absence of nociception, whether actual or potential, the patient will still feel pain in terms of such damage, meaning the presence of a nociception. And that was 55 years ago. Unfortunately, the biopsychosocial model was born there, and then we're still probably using the bioreductionist model, the model reduced to biology, where we need to see a lesion sometimes to believe that our patient is in pain. But there's no secret here. I'm just sum it up in the sensory system, unlike the motor system, on its way through the spinothalamic tract, collecting all the data. Whether it's nociception is not a painful message, it's a dangerous message. And then it stops at a crucial level, which is the hypothalamus and the limbic system before it goes to the cortex. And that hypothalamus and limbic system are the centers of our emotion. So our sensory, or anything that we feel, including a dangerous message, has to be interpreted and analyzed and modulated with emotions before the brain takes a decision whether it's dangerous enough to provoke pain and make that patient defend itself through pain. And that's the power of context, of course. Which you think is more in pain, that guy with a paper cut or that surfer, his leg is bitten, and I'm definitely sure pain is not on his survival list. What are we missing? We are missing to understand the pathways that facilitate the transition from acute to chronic pain. Once this is well understood, then we know why some people shift from acute to chronic, and why some other no. Nociception is neither necessary nor sufficient to generate pain, and opioids are at best marginally effective, unfortunately. So chronic pain, yes, it's a disease and it's not a symptom. And then the complexity is not because all this, it's brothers and sisters, but all the interconnection between them. So we are no more allowed to consider it as a symptom, but a pathology by itself. Can we help? Sleep and exercise. These is a very modest and very short list. The list is extensive. Sleep and exercise are the two most potent analgesic system, and shifting from a bioreductionist model to a biopsychosocial model.
You have 1 extra minute.
I just need 1 minute. And using the most underestimated, cheap, underused treatment of all. Can you guess what it is? It's knowledge. People need to know about their pain and why they're suffering. And these are just, this is the last slide. When you really understand your pain, these are based on explained pain studies, and these are the outcomes of these studies. Your quality of life and sleep improves once the patient is just aware of what he's going through. Your likelihood of full-time work increase, worry decrease, your pain-related expenses reduce, and obviously your pain decrease. Thank you very much for your attention.